Hello and welcome to Everyday Medicine. I'm Dr. Luke, and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues, exploring their special interests in medicine and bringing insights, ideas, and advice which I hope will be applicable for our medical practices. In a moment, we're joined by a colleague discussing colonic polyps. But for Australian audiences, before we start, you can use this as part of your CPD, so please add it to your journaling and your activity statements. Well, colon polyps develop on the inner lining of the large intestine or rectum and are medically significant as a small percentage may subsequently develop into colon cancer. They affect roughly 15 to 40% of all adults and become increasingly frequent with age. And whilst we're now observing an increasing prevalence of polyps and colon cancer in young adults, they are still relatively uncommon before the age of 40 years. Colorectal polyps are found in about 25% of adults aged 45 years. By age 50 years, approximately 40 to 50% of people will develop at least one polyp, slightly more in men than women. Well, polyps generally fall into two main categories: non-neoplastic, including hyperplastic and inflammatory polyps, as well as hamartomas, and potentially neoplastic polyps, which includes adenomas and sessile serrated polyps. Distinct molecular pathways underlie the development of each polyp subtype. And while harmless initially, adenomas and sessile serrated polyps are considered precancerous and may develop into invasive cancer over time. Unfortunately, only a small minority, approximately 5 to 10% of conventional adenomas, and an estimated 2 to 6% of isolated non-dysplastic sessile serrated polyps will ever progress to malignancy. Conventional adenomas progress to cancer via a traditional adenoma to carcinoma pathway, a relatively slow process that may take 10 to 15 years. The risk of malignancy depends highly on the microscopic growth pattern of each adenoma. And in this genetic sequence, APC mutation activates in turn the WNT/B catenin pathway, which promotes dysplasia development in daughter cells arising from colonic crypts. Additional mutations include KRAS activation and TP53 loss result in progressive accumulation of mutations, changing the polyp from harbouring low-grade dysplasia to one with invasive carcinoma. Well, tubular pattern adenomas are the most common subtype, representing about 80% of adenomas, and carry the lowest risk of transformation, with fewer than 5% becoming malignant. Tubular villus adenomas have a mixture of growth patterns and carry an intermediate risk of 10 to 20% becoming malignant. Villus adenomas, although less common, are characterised histologically by finger-like projections of tissue, and these adenoma types carry the highest risk of malignant progression, with 20 to 25% potentially developing into cancer, with the risk increasing as they grow above 2 centimetres in diameter. By contrast, sessile serrated polyps, or SSPs, develop through an alternative biologic pathway characterised by specific genetic mutations including BRAF. They are flat, often hidden under a mucus cap, tend to be more right-sided in location, and historically difficult to spot during a colonoscopy. For an isolated non-dysplastic SSP, the 10-year cumulative risk of becoming cancerous is relatively low at around 2 to 6%. But when dysplasia is present, the malignant potential is much higher. Such polyps may progress to cancer much more rapidly. Studies show dysplastic SSRAs may be harbouring invasive carcinoma in 12 to 23% of cases. For all potentially fatal neoplastic polyps, key risk multipliers for malignancy include size greater than 10 millimetres, the presence of high-grade dysplasia, and multiplicity, that is 3 or more, which indicates more aggressive genetics or colonic environment. By contrast to the adenoma-carcinoma sequence driving traditional adenoma development, sessile serrated polyps develop through the so-called serrated neoplasia pathway, which is commonly associated with BRAF mutations that keep intracellular signalling constitutionally active. This is often coupled with CpG island methylation, which is a process that silences mismatched repair genes, especially the MLH1, leading to microsatellite instability and aberrant cell division. Well, there's a lot of information we've just discussed in relation to polyps, but the bottom line is that colorectal surveillance by colonoscopy is essential. Colon cancer surveillance and screening have been shown to reduce colon cancer incidence by approximately 50 to 90%. And this dramatic reduction is achieved primarily because colonoscopy allows direct detection and removal of precancerous polyps before cancer development. Well, to discuss this important topic in more detail, particularly focusing on large colonic polyp management, we're joined by Dr. Ali Eqbal. Ali has expertise in advanced colonic interventional endoscopy and in inflammatory bowel disease. He completed the 2-year advanced endoscopy fellowship at King's College Hospital, London, where he developed expertise in the diagnosis and management of complex colonic polyps using techniques including endoscopic submucosal dissection, ESD, and endoscopic mucosal resection, EMR. He also undertook a clinical research fellowship in complex IBD at the Austin Hospital in Melbourne. He's widely respected and recognised for his advanced technical skills and commitment to minimally invasive treatment options. He's published and presented both nationally and internationally. Please welcome Ali to the podcast. Dr. Ali Eqbal, welcome to our Everyday Medicine, Ali. It's a great honour for me to have you here and to have you back in Australia and also contributing, as you have already shown, with great skills in our community and joining our practice. So we really appreciate you taking the time to join us. We're going to talk about a couple of different subjects and we'll present this as two different conversations for our podcast series. First of all, we're going to talk about polyps, and then we'll come back at a later point and talk about inflammatory bowel disease and what our screening should be in terms of looking for dysplasia. So, Ali, tell us a little bit about yourself. I'm intrigued about your journey. I can tell you're very popular with all the nursing staff. They love you. You've got a beautiful way about you. And we want to hear a little bit about how you've cultivated your professional abilities. Take us through it.
Absolutely. Thanks, Luke, for having me. And, excited to go through a couple of important topics, particularly, I think, in our day-to-day medicine and in our roles as gastroenterologists. But a little bit about me, originally from Melbourne, the western suburbs, went to high school locally and then sort of went interstate to Queensland and went to medical school there at Bond University in the Gold Coast, spent time there for probably about 10 or 12 years in Queensland. That was mainly because I did some of my basic training there at the Gold Coast and then advanced training around Brisbane and the Sunshine Coast. Completed my training with, at that point in time, a main interest in inflammatory bowel disease. And it was around that stage that I wanted to try and work more in a sort of higher volume unit and sort of in a unit which had sort of complex cases and some clinical research output. So I thought it was probably about time to come back to Melbourne and spent a year at the Austin under the tutelage of Professor Peter de Cruz. We're really sort of honed in on sort of complex IBD, particularly sequencing and therapy, inpatient management, and also dysplasia, which we'll touch on later. And Matthew Choi is another sort of expert in that area. And that's probably where my sort of interest in then polyps came to be, and particularly in endoscopy. And I think both those areas, both IBD and endoscopy, come in hand, particularly with a lot of the categorization and detection techniques and skills that we use and develop. They really come hand in hand. And so my next sort of, goal was to try and go overseas and learn what we call endoscopic submucosal dissection, which really is a niche way of resecting early cancer and large polyps en bloc, which means that we can then potentially offer a curative resection for early colorectal cancer and also reduce the risk of recurrence. And so this technique is a technique that we use. It uses an endoscopic knife to carefully dissect polyps from the bowel wall. And so I went over to the UK, to London at King's College Hospital and worked under the tutelage of Mr. Ahmed Haji and Andrew Emanuel and Professor Boo Hay, who are experts in that area. And so I spent 2 years under their sort of tutelage. I returned back to Australia in April this year. And so I work publicly now at Peninsula Health, sort of part-time, and then obviously part-time with your team as well. And so, at the moment, they're sort of my two main interests and areas that I'm passionate about, one being the endoscopic management and detection of early rectal and bowel cancer, and then as well as the management of patients with IBD. So that's sort of where I'm at the moment.
Well, that's tremendous. That's a great background and great training you've had as well. Did you get some surfing in when you're in the Gold Coast, Ali?
Do you know what? One of my biggest regrets was probably having not picked up surfing, and a couple of my friends became quite good. And I would say, experts in the area of surfing that I sort of spent most of my time just on the beach. But no, it certainly is. If I had my time again, I would have looked at that for
But
sure.
never too late. Tell us a little bit about how you approach polyps. We're all, I think, fairly competent at removing smallish polyps, but you have an expertise, which, we're very happy for you to bring this back to Melbourne, removing large polyps. Take us through, what are we talking about when we talk about large polyps, and how do you approach this?
One of the terminology you might hear is what we call complex colorectal polyps. And by complex, we mean lesions that are, probably greater than 2 centimetres or more, have endoscopic features of potential early cancer or other features such as difficult access. So they're generally what we talk about when we're talking about complex colorectal polyps. But I think before we can even move on to sort of discussing, resection, the most important thing, as you sort of highlighted there, is diagnosis. And we really need to spend a lot of time and carefully examining these sort of polyps to determine what's the best thing to do for the patient, whether that might be piecemeal resection through EMR, whether it's, potentially an en bloc resection such as ESD, or whether or not, really surgery might be the best option for this patient. And so all of that really depends on two things. One, is there obvious cancer? And if there is obvious cancer, then that patient should be discussed in most likely in a multidisciplinary team setting with a colorectal surgical team to determine whether we would go through a segmental resection or whether we can offer local resection through potential ESD or something like TAMIS. So we have other options for local resection. And if you can't see overt cancer, then we've got to ask the question, what's the risk of covert cancer? And a lot of the times, the polyps that we're looking at, even though there's nothing on the surface, there's something beneath the surface. And sort of one of the analogies I like to use with patients is, a glacier. So, we're only seeing a tip of the iceberg with some of these polyps. But what we do know is based on the size, the shape, and the location of these polyps in the bowel, we do have really lots of data that enables us to determine what that risk of covert cancer is. So we have a good understanding and idea of, even if we're not seeing something on the surface, what's that risk of cancer? And so, lesions such as in the rectum, particularly with a nodule, for example, or in the rectosigmoid colon or the left colon, they generally harbour a higher risk of covert cancer compared to those in a proximal colon. In sort of general terms, you might see that risk being around between 15 or 20% in the left colon, and even higher if there's nodules or what we call non-granular lesions. Whereas in the proximal colon, that risk is a lot lower, and large Australian data sets particularly from Westmead suggest that risk is probably around 8%. So when we make that decision based on size, shape, location, we already have a really good idea of what's that risk of covert cancer. And then the next step is looking at the surface of that polyp, and that really gives you a lot of what we call sort of fine details, or then gives you the sort of more fine information as to whether or not this is a low grade, high grade, or potential early cancer. So already, just by morphology, surface characteristics, we're really getting a good understanding of what's at risk. And then based on that risk, we decide whether or not piecemeal resection or resecting it by EMR is appropriate. And often that is polyps that have that low risk of covert cancer, as I mentioned, so such polyps in the proximal colon, or, in places such as the rectum, where there's a higher risk of covert cancer, whether we should be looking for an en bloc resection due to that heightened risk. And so, EMR versus ESD, there's always a bit of a constant battle that we're having as to whether or not one's appropriate or the other, but I think it's becoming quite clear both in West and certainly obviously in Eastern practice where ESD was established, is that in modern day endoscopy, and particularly in tertiary units, there's a right role for both of those particular techniques. And we need to be able to offer that to our patients in order to really, offer them the best service that we can.
Just explain when you do ESD or an en bloc dissection, how deep are you going compared to a submucosal resection?
EMR, good question. So look, the benefits of ESD over EMR in terms of a resection sample certainly is from its histological sample. So really, we are right under the submucosa with a knife, and we have muscle on show, and we are generally dissecting that submucosa right so that muscle is on show. Because with that sort of approach, we are obtaining a really true submucosal sample and reducing the risk of obtaining an R1 resection, i.e. reducing the risk of having polyp at the diathermy margin or dysplasia at the diathermy margin. So that's really the aim of ESD, is to really have that muscle on show and dissect as much as we can and safely as we can.
Getting a clean margin
Absolutely.
underneath the structure.
Exactly.
Yes.
Whereas one of the limitations of EMR is, again, touching on covert cancer, sometimes if you're not aware of that covert risk and you do resect something by EMR, a really difficult thing to then deal with the patient is when there's dysplasia at the deep margin, whether that's high grade or adenocarcinoma. That's a difficult conversation to then have with the patient, because are we then going to offer surgery, potentially overtreat or undertreat, and the patient has recurrence? So that's sort of the difference there. And then probably another level, which we don't necessarily need to go into today, but we do also have the option of what we call intermuscular dissection in the rectum, where we can dissect between the circular layer and the longitudinal muscle layers. And that allows us for a deeper resection while maintaining the muscular longitudinal muscle bed. And that also helps us resect early cancers or even deep T1 cancers. So T1 cancers with submucosal invasion greater than 1,000 micrometers. And that also then gives us, again, a nice en-bloc histological sample that's R0, that then gives us all the additional histological information for a patient to determine, look, I'm happy with this risk. This is a low-risk cancer. I don't want anything else done. Or they might have a poor prognostic tumour. They might be poorly differentiated or have lymphovascular invasion, and they say, yep, you know what, I'd like to have further surgery and lymph node harvesting. So the true purpose of it is to get that histological sample that you can then tell to a patient, this is what the sort of tumour is that you have, and these are your options moving forward, whether it's definitive surgical management for lymph node harvesting, or in someone who is perhaps a bit more older or a failure and wants to focus on their quality of life, it's a watch and wait approach. So it's giving you the ability to tailor that management to the patient in front of you.
So we've got this wonderful technique that allows you to really remove the entire structure, possibly with some tumour cells within it, in one piece. Allows you much better histological confirmation of what's going on. And that must be rather hairy, I would think, Ali, dissecting down between these circular layers of muscle. I think there would be a real potential to see a little bit of momentum from time to time, or some other gap, and you're wondering what that space is whilst your heartbeat just rises a little bit. Tell me, I'll come to that in a moment, like the complications, but how can you tell, like before you do this, that lymph nodes are not involved? How accurate are we in determining that?
Yeah, it's a good question. So, look, radiological techniques are generally what we would use initially to assess for lymph node involvement. So, in the rectum, for example, if you had an endoscopic suspicion for a rectal cancer, then we would use an MRI to look for local lymph nodes. That it's not perfect, but in terms of non-invasive measures, it's certainly the most appropriate non-invasive way to look for lymph node involvement. And so we really then also rely on our endoscopic assessment, not just our radiological assessment as to the staging of rectal cancer. And so we generally do have the ability to determine whether we think this is a T1 rectal cancer or greater than that. And that's also when MRI comes into the picture as well, because it will give us the accurate T staging, not just the N staging, but usually it gives us the T staging.
Just define the T stages for us here.
Yeah, so it'll give us an idea of the depth of tumour invasion through the layers of the muscle. So whether it's T1 localated to the submucosa or T2 involving the muscle, or it's through the muscle T3 or through the serosa T4. MRI is reasonably accurate at determining whether something is T3 or greater, but it's not great at determining whether something is T1 or T2. Although in saying that, there are some fantastic radiologists who are specialists in MRI rectum, and certainly some of the ones in Europe and overseas are as well. I'm sure locally there are too. And, some also have the ability to give you the depth of T1 invasion, whether it's early or deep T1. So there's some variability in terms of reporting, as with any medical specialist and experienced specialist. So we generally like to look at our endoscopic assessment and then combine that with radiological assessment if we think that there's a potential risk.
So I think the sort of modern approach now we're saying is we've got a large structure in the rectum. We think that this, based on endoscopic appearances, might be resectable. Probably there may be some situations where we're thinking an EMR is okay. We can remove it piecemeal. We're not going to get as much definition of the tissue because we're removing it in pieces. But we're reasonably confident there's not going to be occult cancer within that tumour. Otherwise, we're going to go for maybe an ESD, but before that, we're going to be thinking about imaging. They're probably going to have CT scanning and then also MRI. And that's really our sort of modern approach to these structures now. Ali, is that right? That's what we should all be thinking about. And in
Exactly
private
right.
practice, we shouldn't think necessarily, oh, it's just going to be surgery. Later, misere, we should be thinking, actually, there's another non-invasive, smarter way that might really be beneficial for our patient, particularly our slightly older patients.
Yeah, exactly right. I mean, I think, and we spend a lot of time on this, and I try and spend a lot of time on this with our registrars, and this was really hammered into us in our fellowship. We spend a lot of time just on diagnosis. And I think if you can get that diagnosis right, give us an accurate morphology or, shape or size, location, and a surface pattern, then I think you've done a really good job for that patient already. I don't think we need to be in a rush to resect that sort of polyp in the index procedure. I think it's important to take some nice photos, make an assessment of what you think is going on and that risk of covert cancer, and then discuss it, obviously, with a patient and a colleague who may have that sort of ability in terms of resecting these sorts of lesions. So, as you said, low-risk lesions, EMR might be appropriate. In the rectum, obviously, however, we're just going to keep in mind that even with EMR in the rectum, recurrence can be a problem. And recurrence anywhere in the colon can be frustrating, but particularly in the rectum, because we don't want to perform surgery for recurrent lesions in rectum, because it's, rectal surgery can be quite morbid. So that might also sway you a little bit more towards ESD. And then, as I said, naturally, anything with a reasonably high risk of covert cancer or surface features of it, we should be thinking about en-bloc resection and ESD.
Are you comfortable performing ESD also in the right colon, even though perhaps the risk of, neoplasia in these big polyps is a little bit less? You've got a thinner wall there. Take us through that. Are you confident performing this in any part of the anatomy?
Yeah, look, certainly I think at this stage in my training and career, I'm comfortable just remaining in the rectum. I think we need to try and hone our skills and show that we've got great outcomes and numbers at our local unit before we look at the proximal colon. That's just from a personal perspective, given that higher risk that you mentioned. But certainly in the right pair of hands, doctor with the right amount of training and with the right lesion, ESD remains an appropriate choice, particularly again, for, as we said, lesions that have surface characteristics of cancer, so non-granular lesions that might be greater than 3 centimetres, or lesions that have surface characteristics such as 5R low grade, or what we mean early cancer or high grade. So, I think we're going to pick that right lesion and in the right pair of hands. Yeah.
Well, that's great. So a careful workup and diagnosis. When there are complications, it's always very distressing for everybody. Of course, the patient, also the proceduralist, which, would be you in some instances. Take me through how you handle that, Ali. When there's a complication, we're talking perforation or significant bleeding, what are your approaches there that can assist in preventing that patient from being taken for more formal surgery?
It's a good point. And I think you really have to be aware of what your options are when you encounter a complication and assess the severity of it. And this is regardless, I think, of whether it's EMR or ESD, but assessing the severity of that complication. And I guess taking a moment to decide whether this is something that is endoscopically manageable and whether it's something that's going to halt or abort your procedure. So if we go to EMR, for example, you might encounter bleeding, or, let's start with bleeding, for example. Usually with bleeding, majority of the time, we generally have good endoscopic means of managing bleeding. So whether it's with clips or with coagulation forceps, it's not common to, I think, encounter bleeding that's so significant that you can't manage it endoscopically. Perforation, though, can be different. Now, immediate perforation, we usually will see it at the time of the resection. And we have, as I'm sure you're aware of, target sign or interruption in that muscle layer. So you have to be able to recognise it. And again, I think in sort of modern endoscopic practice, we are in a position where if we do recognise something early enough, we do have the ability, particularly with clips, to manage that. So I think the approach there is recognising your complication early and knowing what you have in terms of your endoscopic techniques to manage it. And, of course, in those scenarios, important to consider admitting the patient and observing them and, engaging your colorectal colleagues if there's some concern clinically and then radiologically. In ESD, it's probably a little bit different depending on where it is. In the rectum, depending on where that lesion is and complication, if it's perforation above or peritoneal reflection, then we have a sort of the heart rate will obviously climb a bit higher if it's above that reflection, because the risk of certainly sepsis is a lot higher, whereas where it's below, we can generally manage that, whether it's by just dissecting proximally to it, removing the lesion and closing that area once it's been completed. So I think in ESD, we have the ability to manage those issues as well. But depending on where it is in the colon, obviously the implications of it can be different. But from a personal perspective, I think is what you're asking, and from a patient perspective, yeah, look, I think it's really difficult. I think first and foremost, we always have to make sure that we've discussed that procedure and indication and the consent with the patient appropriately.
Yes.
Spoken to family members as well. And we often try and give them options. You know, your options are whether endoscopic treatment of a possibly benign lesion or whether you want surgery for these sort of lesions. So we try and carefully go through each of these options before we encounter the procedure so that, you know, they're aware of what they were going into. But of course, that never makes it any easier. And then obviously closely following them up after the procedure to see how they've recovered, answering any questions, and speaking to their family about what happened as well. From a personal perspective, I think it's really helpful to always go back and watch what you've done. So it's important to look at some of the endoscopic videos and images to see where you made that mistake. And I think you can learn an incredible amount about where you've gone wrong in that. And that's probably one thing I started to do in my second year of fellowship that I didn't do enough in my first. And I must say, there's a lot to learn just from rewatching that. And sort of, it really does give you harsh lessons. But it's important to do that to make sure that we're offering the best thing that we can for our patients.
Well, Ali, thank you. Really what we're seeing is a new paradigm in the way we're managing big polyps, so localised cancer. We're now seeing the gastroenterologist, people like you with your skills, Ali, which we're very happy to have serving us locally, providing another less invasive method to assist patients. And I think it's very important that in primary practice, everyone realises this is the way we are now going with a lot of these structures. We don't have to necessarily have major surgery, which could result in a patient having a stoma and losing control of their rectum altogether. We've got different ways of managing patients. It's very important we understand that. So we thank you for bringing those skills and explaining this so nicely today. Tell us one little thing, best advice that perhaps you've been given as a doctor. Could you think about something that one of your mentors perhaps brought to your thinking along your wonderful journey?
Yeah, that's a very good question. I think, as you sort of highlighted just then, it's being able to offer patients personalised treatment decisions. So we can do all of these things that we discussed, whether it's local resection, surgical resections, nothing, chemotherapy, all of these options. But we're in a state now in medicine, and particularly with, you know, colorectal cancer, where you can offer the patient either one of these options, and either one of them might be appropriate. But it really depends on what the patient would like and their quality of life and what the implications of treatment or complications would be for them. So I think that was a valuable lesson. One of my mentors likes to give me an example of a patient who really didn't like the idea at all of undergoing, you know, surgical resection for a colorectal cancer and having an anastomosis, and thought, look, this was going to interrupt their quality of life. And so they elected us for a stoma instead. So, you know, there are patients who, for, you know, that sort of approach would suit their lifestyle, and that's important to them, and for others that might not be. So I think always remembering who that patient is in front of you and thinking about, you know, what their wishes are and allowing them to make the decision, empowering them to make that decision.
Ali, thank you very much. I'm looking forward to you joining us again for a discussion on inflammatory bowel disease. We'll see you again soon. Thank you.
Pleasure. Thanks, Luke.
Thank you.